Thank you so much, friends, for spending your afternoon with us today with our clinical and regulatory review topics. I know our physicians at Cumberland are just joining us, and they have been part of a series of disease-specific topics that we've been talking about. Today's topic is CHF, and we'll start with our usual introduction to the learning management system, and then talk about some of the topics that we are going to cover over the next few months, and then go on to CHF. So for some of the people on the call, they have access to the learning management system. They have a subscription to it, and it's an easy way to get onto it. Go on to aerolib.com, scroll down to Aerolib LMS, and then it opens up this Adobe Captivate login page. Most of the people on the call already have logins for this. Once you log in, you'll see your picture here once you upload it. A lot of topics on the skills map, your badges, some of the common topics that are already on. We have more than 20 topics on disease-specific documentation right now. There's more about the 2 midnight rule, the MACRA, the MIPS, the EM documentation 3-part series coming along. So click on any of the topics, say for example acute kidney injury. It should open up this page where it gives you information on the core content about acute kidney injury videos, references, PowerPoint slides. As soon as you click on one of them, it starts this recorded webinars. We have tracking capability on how many people have logged on, what sort of topics they've viewed, what sort of scores they've given, who's completed what portion of the topics. You all have access to the free Aorta app on the Android and the iOS platform. As of last month, we had about 78,000 views. We have 166 active members that are posting as well as reading material on their iPhones, iPads, on their Samsungs. What we've done over the last few months is looked at the top 15 DRGs that cover hospital admissions and reimbursements associated with that. Now, when the CMS 1599 rule, the 2 midnight rule came along, even though it was felt that it would change the way documentation would happen, I think when you go through our clinical and regulatory review topics, you'll notice that this is basic medicine. But what we do talk about is, how these documentation tips need to be looked at from regulatory and payer standpoint. And so these are some of the other topics that you'll find on the LMS. A little disclaimer saying, CPT belongs to AMA, Interqual belongs to McKesson. Now, people who have attended our webinars know that we always start with this slide. And what this is to give us an impression on who's watching us, who's watching the healthcare community. And when you look at the 2 bottom green ones, the certs and the QIOs, they are actually for routine compliance. They actually help the hospitals. The RACs, MICs, and MACs, again, they have attained some notoriety in terms of holding payments, but they are essentially for compliance oversight. And then once they report that something isn't right, reports go on to the DOJ, the OIG, and the ZPIC. Now, add to this the insurance companies that are now sending these notice of improper payments and recoupment. And then what I'd like to touch about, and again, this is just the tip of the iceberg about the MACRA and the MIPS and the alternative payment models that was discussed in one of our webinars. These are payment models that are looking at 2016 as the base year, and these will affect payments as high as up to 2021. And this is pulled out from the CMS website. They talk about fee schedule updates, and if you're in the MIPS, on what sort of payment adjustment will happen. One thing that everyone needs to know is this is going to be a budget neutral process. So it essentially means that people who aren't performing well are going to have their payments cut, while those who are doing what should be done are going to have payments increased. But essentially, what CMS is trying to do is make you compete against your own peers to do the right thing. Now, part of what they want to do is quality metrics and value-based care. and CMS at one point had stuck to this conclusion that good documentation is what defines value-based care. Which is why, when you look at our topics, these are all catered into making sure the documentation is rock solid. And if it is so, you should be comfortable on not losing any payments till 2021. And then when you look at 2022 onwards on the timeline slide, this is a long-term goal process for CMS. And the key point from a financial standpoint is budget neutrality just makes this very evident that the poor performers are going to lose money, while people who perform according to what CMS wants them to should see an increase in reimbursement. Now, this is something that I think everyone on the call knows, that auditors are looking at cases, and what they're essentially looking at, are the services reasonable and medically necessary. Now, medical necessity is one term that encompasses pretty much all sorts of payment denials. Auditors also look at meeting professional standards of care, and this is what we'll talk about on the CHF modules. And they always see, can these services, can they be provided in another setting, which is, why should this patient be in the hospital? Can we not provide it at home through home health or a nursing home or assisted living facility? Now, this was some of the next two slides have been pulled out from the CMS CERT reviews, and people who have access to the LMS can pause at this time and read these next two slides. But just a summary is, kickbacks, inducements, false claims, gang visits, double billing, date of service, identity issues. They talk about misrepresenting who rendered the service, false coding or services, unnecessary care, and a lot of the audits are now coming under this category. Physicians and healthcare personnel no altering medical records or late entries, there's a where to put that in. Delay in care, and that's what CMS has identified as gaming of the system. But feel free to pause at this time when you're in the LMS and looking at these presentations. What I'd like to show you here is how do the auditors actually find out the key correlation of your documentation. And so we also do the 3D mapping of clinical data. And when you look at this slide, there's some busy balloons in them, but these are all documentation keywords that we can link for H&Ps and progress notes and discharge summaries on just congestive heart failure. Now, as you see, the balloons on the periphery mean those words have not been used as frequently. Balloons in the center are the ones that have been used more frequently in documentation. And what CMS does is, and they've spent millions of dollars in this sort of program to find out what are the most common documentation points that are needed for each DRG. In this case, it's CHF. And then they can plot the proximity plots on terms of how good or how near is this documentation to your core diagnosis of CHF. So, for example, if you're doing acute exacerbation of CHF, but your key core words are pedal edema, tachycardia, and cellulitis, the pedal edema, the tachycardia, the coarse breath sounds will be closer to the CHF diagnosis, and the cellulitis will be in a balloon way far away. And this is how they formulate the line charts as well as concurrent reviews of these cases. So in cases of CHF, they figure telemetry, LASIX, blood counts, consultations, echocardiogram are in the central of CHF, while some cases require breathing treatment, some require oxygen or not. But this is the level of depth they can go on to each and every case before they pull out for audits. So let's start with our clinical and regulatory review of CHF. People who have attended our sessions before know we talk about definitions, some pathophysiology, some signs and symptoms, talk about some CCs, MCCs, ICD-9 and 10, and then what the screening tools are, and then give you some coding tips on CHF. So why is CHF important? Well, you see the $4 sign. It just means it's an expensive disease. And in 2011, the aggregate in-hospital costs were more than 10.5 billion. This is a study that was published by the Agency for Healthcare Research and Quality, and CMS generally trusts these numbers that come out. So, question is, who's responsible for CHF definitions? Well, and I'm going to go through some. There's the Heart Failure Society of America. It has its mission. They have some documentation guidelines for us. We have the American Heart Association, and they have come out with this huge campaign about understand heart failure, identify your needs, explore heart failure options. So more education that's being provided, not only to the healthcare community but to the end consumers, to our patients. There is the American College of Cardiology, which has come out with a lot of resources. CardioSource is one that actually gives us some clinical guidelines, but they have quality improvement for institutions. They have the National Cardiovascular Data Registry, the CardioSmart, and then the Society for Cardiovascular Patient Care. And what I will do is, when I typed CHF guidelines in the ACC, there were 38 guidelines that came out, and some of them are for primary care, some of them are for cardiologists. One of the articles that you see is the performance measures for adults with heart failure. So not only has the ACC said, we'll give you definitions, but now they're telling us what needs to be ordered, when it needs to be ordered, what's the dollar amount associated with that. So trying to take some accountability in the recommendations they give for management of CHF. Then they came out with the 2016 new pharmacological therapy for heart failure, and this was an update to the 2013 guidelines. Now, I know in previous discussion, some of the audience had asked if they should take notes. These slides are going to be available to everyone in the who has subscription to the learning management system. All links to these articles are to the end of the PowerPoint slide. The ACC also came with the 2013 guidelines for management of heart failure, and then followed it up with the 2016 updates. In the 2013, again, this is a 93-page document. The idea is not to discuss clinical definitions of CHF or management, but just to say, to let you know that auditors have access to this data. I mean, I've done auditing for hospitals, for physician groups, and we look at what's out there, what is the evidence-based criteria out there. And what has been different from when I started med school and residency is, diastolic heart failure is an entity that they don't encourage to use. And you can see it's heart failure with reduced ejection fraction, which is the systolic heart failure, less than, EF of less than 40%. And then the ACC also says heart failure with preserved ejection fraction, which is EF of greater or equal to 50%, which is commonly referred to as the diastolic heart failure. Now, why this is important is, some payers are trying to focus on using these definitions when you're writing your documentation in H&Ps. The healthcare audience and the physicians in the group know this. This is basic med school stuff. How do you define heart failure? There's congestion at rest if it's yes or it's no, and then there's low perfusion pressures or low perfusion at rest, or narrow pulse pressures, or hypotension, and there's a no, yes. And depending on that, you classify it into warm, dry, warm, wet, cold, dry, cold, wet. This actually helps in guiding management also. But look at the variables that are used to determine this. Orthopnea, elevated JVP, Rales, S3, edema, and then pulse pressure, cool extremities, and hypotension. Now, where this is guiding us is these are the exact same points we need to put in our H&Ps and our progress notes for patients with heart failure. Sorry. So the NYHA class treatments, and again, this is very common. People on the call can pause when they're looking at this on demand through the LMS. But again, loop diuretics, hydralazines, nitrates, aldosterone antagonists. Idea is not to treat management at the time, but just to make sure that when you are admitting someone for CHF, you need to focus on justification of what the treatment is. if you add someone coming in for CHF and say we'll just continue their home dose of oral diuretics, it doesn't justify the intensity of service at that point. And again, this has been pulled out from the ACC guidelines for heart failure. These are free for everyone who goes to the American College of Cardiology site. It's something where they talk about staging A, B, C, D, and then talk about treatments. But this is a lot of the stuff that the clinicians on the call already know about. I've opened it up, enlarged it to show that when we are doing therapy, a lot of this needs to be in our progress notes. Simply saying CHF protocol per hospital, that's not justification of full documentation of intensity of service. The auditor may look at the case 2 years from now. Your guidelines or your protocol for CHF may have changed, and so there is no way to know what you ordered that required the patient to be in the hospital. So there's some documentation guidance, and this has been pulled out from the guidelines. There's early triage should be performed to determine whether an emergent or inpatient care is needed, and that's where the ER comes in. So let's talk about some unstable symptoms. Now, dyspnea at rest, orthopnea, that is, there needs to be a change from baseline, sudden onset of shortness of breath, worsening shortness of breath, exertional dyspnea, gasping. Now, people on the call have already taken my hint that this is the terminology that's actually required in progress notes, in discharge summaries, in H&Ps. So pulse oximetry less than 90%, coughing up pink and frothy sputum, whether there's interstitial edema, pulmonary edema, whether there's dizziness or syncope, chest pain, systolic blood pressure less than 80 to 90, and this is an indication of hemodynamic instability, or evidence of hypoperfusion. Is there cyanosis? Is there a decreased level of consciousness? So documentation guidance is, consider hospitalization in the presence or suspicion of heart failure with any of the following findings. They could be clinical findings, lab findings, EKG findings of MI or infarction, heart failure refractory to outpatient therapy. If that is indeed the case, a documentation in the HPI needs to show that we've been trying to manage the fluid status on patient X with increasing doses of diuretics and potassium replacements over the last 5 days as an outpatient. However, there is worsening peal edema, there is JVD on examination today, and I can hear crackles and rails. So it does show that you made a good faith attempt to manage this patient as an outpatient. Chest x-ray findings of pulmonary edema or clinical findings of respiratory distress, whether they are thromboembolic complications or severe complicating medical illnesses. Does the patient have concomitant renal failure or pneumonia, or whether it's healthcare associated or community acquired. Now, if there are arrhythmias, that generally helps to bill as an inpatient, and a lot of the peer-to-peers that we've done when we have heart failure, and whether it's ventricular tachycardia or sinus pauses, any form of arrhythmia does show that there is the intensity of disease process is much higher than a simple CHF. Generalized edema, whether there's liver failure in addition to the CHF. Inadequate social support for safe outpatient management. Now, this has come up in a lot of the CMS open door forums, and it's a gray area on how do you define adequate social support. A lot of the physicians have done some great documentation in saying, this is a 90-year-old lady with an EF of 20%, 4 falls in the last 3 days, there's closed head injury, but there is no support at home, or the home situation hasn't been assessed. Now, using the same argument for a 50-year-old with heart failure who comes in because she ate a bunch of hot dogs over the July 4th weekend, and then you say, well, she's non-compliant, those are two different things in terms of trying to document a safe outpatient management plan. But those are things that we need to be careful of when we are documenting our CHF cases. Again, hyperkalemia associated with EKG or without EKG findings. Now, when you have a potassium level of 6, an auditor will always look for EKG and your interpretation or your documentation of whether it was done or not. Simply because this is basic knowledge about hyperkalemia, EKG findings, and arrhythmias. So diagnosis of heart failure, and again, Framingham criteria tool have been around for years. And what they have said is either two major criteria or one major and two minor. So when you look at major criteria, and again, why I'm reading this is what is going to be very important in justifying CHF in terms of your H&Ps, progress notes, discharge summaries. So paroxysmal nocturnal dyspnea needs to be in the HPI. Neck vein exam and rails need to be present or at least documented in your examination. X-ray findings of whether cardiomegaly or pulmonary edema need to be put in. Diagnosis of acute pulmonary edema when you are auscultating the patient, presence or absence of an S3 gallop. CVP in case you're putting lines in, hepatojugular reflex in another examination maneuver, and then historical weight loss greater than 4.5 kgs in the last 5 days. Now, minor criteria, ankle edema needs to be part of your examination, nocturnal cough part of your HPI or review of system, dyspnea on ordinary exertion, hepatomegaly on examination, pleural effusion on examination or on your assessment of X-rays or CTs. If you can do pulmonary function testing, but whether there's a decrease in the vital capacity, and then tachycardia, part of your initial triage, your examination can be found out through EKG, and a lot of the nursing concordance notes document about heart rate issues. So when you look at this, now this sort of description of a patient of heart failure needs to be in an independent daily note, whether it's part of an H&P, whether it's part of a progress note or a discharge summary. And we are doing peer reviews for ER physicians for one hospital. This needs to be part of their T-sheet. The beauty about it, ER T-sheet is it's all written there. All you need to do is check mark it or not. But the moment you do not do anything or leave it blank, that's an indication that all these assessment of these major or minor criteria were not done. So what does Interqual say on CHF acute? And I've talked about this for many years now. Interqual or Milliman, they are not creating medicine. They are technically using what we learned in med school. So they are using the same Davidson's principles of medicine, the same Harrison's principle of medicine. Some of the peer-to-peers that we are doing and denial letters are actually quoting up to date, which is again a reflection of Harrison's, so basic medicine. What Interqual has talked about is heart failure confirmed by imaging and dyspnea at rest or greater than baseline after 3 hours of ED treatment. They talk about pulse oximetry. They talk about BN and creatinine, talk about altered mental status, heart rate, and then failed outpatient treatment. So this is exactly the same of what we were talking a few minutes back in terms of how do you define CHF. Interqual talks about right heart failure, and they say we need all three of these. So there is lower extremity swelling, there is weight gain, and there is dyspnea at rest. Again, a reflection of basic CHF documentation. Now, CHF Interqual criteria for acute, they talk about new onset heart failure, left heart failure, which is confirmed by imaging or dyspnea at rest, and then right heart failure about the peripheral edema, hepatomegaly, and JVD. Again, all basic med school, residency, examination, and historical data that we should have. Now, heart failure with preserved left ventricular ejection fraction or the diastolic heart failure, there's dyspnea on exertion but hasn't returned to baseline, and then oximetry of less than 89. What you will see over the next few auditing through insurance companies is this gray area of whether it's 88% pulse oximetry, 89%, 91, 88 on X liters of oxygen. And I think this is where they want the documentation, both from the physician, from the respiratory therapist, as well as from the nursing notes to be concordant. So if the physician says, 97% on room air, but respiratory therapist says, well, we forgot to add the oxygen, it's actually 92 on 4 liters. That's a reflection that the moment you take off the oxygen, the patient's going to fall down to 84, 83, or 82% oximetry. But again, concordance between all healthcare providers is very important for not only CHF, but for all cases. But in this particular case, pulse oximetry seems to be the hinge on which a denial of inpatient and outpatient can happen. So why is CHF patients, when they say it does not meet interqual, so, ER physicians, they're incentivized to make rapid disposition decisions. That's the function of the emergency room. And then in the ER, the goal is rapid throughput. So they want, as soon as they identify a patient, start the treatment, they want this patient either admitted or handed over to the hospitalist or cardiology teams. Now, a lot of these patients who have CHF have already concomitant disease. They're on beta blockers. And so you may not see the tachycardia, but it's important to document heart rate of 90 on 50 milligrams or 100 milligrams of metoprolol, so that when someone an auditor is looking at the case, they know that 90 for someone on a high dose beta blocker is actually equivalent to 150 on no beta blockers. Now, if oxygen is applied by the EMS or the triage without checking the room air oxygen saturation, well, you may never have a baseline pulse oximetry on room air, or what we call the distress oxygenation level. So clinical judgment, this is where, when physicians are doing peer-to-peer, they don't look at interqual or Milliman or stick to their criteria. What they talk about is how sick this patient is. So a low normal oxygen on supplemental oxygen is not a normal oxygen, which is what I was saying. It indicates significant hypoxemia. There is a very good presentation by Dr. Chada on the LMS on acute respiratory failure, and it gives you exact numbers on what a pulse oximetry with and without oxygen, what does it imply in terms of arterial levels of oxygen that are seen in the body. So hospital admission recommended. So there's evidence of severe decompensated heart failure. There's hypotension, worsening renal function, there's altered mentation, there's dyspnea at rest, which is reflected by resting tachypnea, and then oxygen saturations of less than 90%. But again, this is a repetition of what I've been saying over the last few slides now. So hemodynamically significant arrhythmia, including new-onset AFib with RVR, acute coronary syndromes. If you have these along with CHF, make sure you document them. Make sure you write what the EKG findings showed. Make sure you write what the troponin levels were. So when should hospitalization be considered? Now, worsened congestion even without dyspnea, and these are the gray cases that we see. Patients who have systolic heart failure on Lasix may have gained 1 or 2 pounds, feeling short of breath, but couldn't come to the ER yesterday or day before, and now come with these congestive findings. They should be hospitalized. Do what's right for the patient. Again, inpatient, outpatient, those are all billing scenarios. Those should not affect what treatment or care the patient is receiving. Signs and symptoms of pulmonary or systemic congestion, major electrolyte disturbances, and then, like I said before, associated comorbid conditions, whether there's a pneumonia, there's a PE, DKA, TIA, or stroke, hospitalized, do what's right. A lot of patients have had ICDs, and some of them may present with congestive symptoms, AFib, with rapid ICD firings. They need to be kept in the hospital. The device needs to be interrogated. Now, if it's a previously undiagnosed heart failure with signs and symptoms of systemic or pulmonary congestion, and these are the cases that I think a lot of us see, visiting patients who come in from different states, who may say they have nothing acute going on, no history, and then when you look at them, it's heart failure, you hospitalize them, the echo shows 30%, the troponin comes out elevated, all these patients should be hospitalized. So inpatient. So patient in significant distress after ED treatment. And again, when you are trying to decide whether a case should be inpatient or observation or outpatient in a bed, see what the severity of illness is, what the intensity of service that you're providing is. So patients with active chest pain, that's the primary complaint. Patients needing BiPAP. Any patients who require hemodynamic support, so dopamine, nitrates, epinephrine, norepinephrine, those are things you just cannot provide in an outpatient setting. Coexisting disease. So someone comes in, blood sugars are 200, A1C is 9, and patient presents with heart failure. We've had cases where those have been put in as inpatients saying they had major coexisting disease. Having said diabetes is a killer, an A1C of 9 is not going to kill them today. It's the heart failure that's going to kill them. And so that may be a comorbid condition, but it just doesn't justify putting that patient as an inpatient. And again, each of them is case by case basis. An A1C of 16 with blood sugars of 800 in DK is completely different than someone who's hovering in the A1C range of 7 or 8 but just uncontrolled. So be careful of these inpatients. So when an HNP has patient in no acute distress or lying flat, or other descriptors of a very comfortable patient, and this, when I talked about concordance of notes, when the ER physician or the ER discharging nurse says patient in no acute distress, vital stable, the HNP is done an hour later by the hospitalists who say the admitting pulse ox was 82, now 97% on room air, and the nurse agrees with 97% on room air. A lot of times, you start wondering, if this patient is so stable, why do we have to keep them as an inpatient? I mean, we definitely should hospitalize them, give them some doses of diuretics, breathing treatments, oxygen, if there's COPD, some rounds of steroids, but it doesn't need to be an inpatient. So patient not needing any oxygen, again, in CHF, oxygen levels and the need for oxygen therapy is one of the major audit findings that auditors are looking for. Vital signs and labs that are basically normal, and then if pedal edema is the only complaint. So not everyone who presents with 2+ pedal edema is in heart failure. So let's be wary of some observation findings. So patient has a comorbid condition that predicts a longer stay, especially renal insufficiency, needs more than nasal cannula oxygen, maybe high dose meds, Lasix or Bumex infusions. So once a patient starts needing a continuous infusion of Lasix and Bumex, that means that an inpatient stay is appropriate. So there's a last line saying cannot use inappropriate treatment to justify inappropriate inpatient care, and I think this is not only for CHF but for every diagnosis. Now, one topic that has come up in my discussions with physicians on CHF is, well, the BNP was high. So BNP is irrelevant in terms of describing severity. It's a useful diagnostic tool to say that, yes, there is a left ventricular stretch and there is an element of heart failure. But again, BNP is useless if there is renal insufficiency. It does help differentiate between CHF and COPD. So someone comes in with shortness of breath and BNP is 50, it's unlikely that there will be CHF. If the BNP is 16,000 and this patient is on end-stage renal diagnosis but completely stable, BNP is just a lab. It doesn't predict heart failure in patients with renal failure. So a high BNP is not per se an indication for inpatient care. You don't need to repeat serial BNPs to show improvement in treatment. And I've seen that happen in some of the facilities where they're doing daily BNPs. That's just not required. Some of the slides here that you'll see about comorbid conditions, these are specific to CHF. And everyone who's attended these sessions in the past, does know the CC means for the comorbid or complicating conditions, and the MCCs are CCs that contribute substantially greater severity than a simple comorbid condition. And these are defined in the Federal Register. For cardiovascular, they've talked about acute MI, unstable angina, blocks, flutters, the absence or presence of previous CABG surgery, and then hypertension, accelerated or malignant. And again, feel free to pause on this slide once you're reviewing it at your leisure on what it is about the CCs and MCCs. There's obviously brain death, there's CVAs, there's coma, endocarditis, again adding severity that this patient needs to be in the hospital. I'm going to talk about some numbers now. So say someone comes in with heart failure and shock and they have COPD. There's a DRG of 293 and all that's documented is heart failure shock with a history of COPD. The payment to the hospital is roughly in the range of $5,700. This is from one hospital in the central US area that we've pulled out from CMS data. Now, if this patient has heart failure shock, there's COPD and there's hypoxia, and it's unknown whether that hypoxia is a exacerbation of heart failure or from COPD, but documenting hypoxia in your notes does bump up your DRG as well as your payments for the DRG to about 7,000. Now let's look at this heart failure and shock, and then there is acute COPD exacerbation with hypoxemia and hypercapnia. And you may have treated this patient in the ICU for a day and then back to tele for second or third days. But the DRG is different because there is a major comorbid condition now, and the payments are about 8,800. So it may be the same patient, but your documentation is now more specific, or the patient worsened during the first or second day, and now this is what your documentation on day 2 is. But again, it does bump up the reimbursement. So just to recap on documentation to support diagnosis, well, there is absence or presence of paroxysmal nocturnal dyspnea, neck vein examination, very important, RAIL, so respiratory examination, important, imaging, whether it's CT, whether it's chest x-ray, that needs to be on your H&Ps, progress notes, discharge summaries, absence of presence of pulmonary edema, cardiovascular examination documenting absence of presence of S3 gallops. Now there's, it took me a while many years ago to learn what an S3 sounds like, and nowadays all you need to do is YouTube S3 gallop and you'll have 100 findings on what it sounds like. But auditors still look at that. It may be easier for you to order an echo and tell us what sort of valvular problems there are, but they still look for examination findings when they are trying to find out severity of illness. Now CVP, hepatojugular reflux, this is an examination finding that a lot of people don't do, but again, easily done, easily seen, and then if done, needs to be documented. Again, simply YouTubing it can give you on what you need to look for when you're doing an abdominal exam with hepatojugular reflux findings. Review of system, weight loss. So very important for CHF patients to have not only eyes and nose, but daily weights. And those weights need to be documented in similar fashion. If it's winter and you're weighing someone in an overcoat, and then 2 days later you've taken the coat out and there's a 10 or 15 pound weight loss, make sure it's a standardized weight process. Some of the patients who present are so sick that you need to do it with the hospital bed weight system, and those are slightly more standardized. So ankle edema, nocturnal cough, dyspnea on ordinary exertion, hepatomegaly, pleural effusion, decrease in vital capacity, and then tachycardia. So all basic examination findings that need to encompass a CHF case. So when you look at ICD-10, why we need to document so specifically is ICD-10 has just given us some more codes, and the more number of unspecified codes that you use, the lesser reimbursement it's associated with it. So they are very specific, and to the people who have access to this, even Googling ICD-10 or pausing on this slide and looking at how specific they want to be is going to be give an indication on what your progress notes or what your assessment and plan or medical decision making should show. Now, this is one slide that everyone is now very familiar with. Why does this patient need to be in the hospital? So what is the condition that can only be treated in an acute care facility? And if so, what's that treatment? What's the condition? What's the treatment? Now, these two things should be answered pretty much on a daily basis, not only by the physician, but even by the healthcare team, the nursing staff. And this is what defines medical necessity of continuation of stay, and this is what CMS is looking for. A lot of the places can have documentation writing, patient appears good, vitals are stable, maybe give another day of IV Lasix, see how she does tomorrow. Well, that's if this patient is eating, and an auditor will look at what the eyes and nose are. If she's eating IV Lasix or oral Lasix, and oxygen levels of 97 on room air, clearly that day is not a medically justified day. So Medicare releases these quarterly compliance newsletters, and these are guidance to address billing errors. So they have talked about a number of conditions, and CHF is one of them. Comes back to our previous slide about CHF and high dollar amount. So it is an expensive disease, which is why Medicare had put CHF in its 30-day unplanned readmission and death measures list. So very important for you to document. If your patient is stable on day one, you need to document vitals, X-ray findings. You need to document the discharge plan, and if this patient comes in before 30th, the 30th day as a readmission for CHF, that documentation in the HPI review of systems needs to document what exactly happened. A lot of times, non-compliance or just not understanding the complicated medication regimen that this patient gets could be a reason for this patient to come in. Unfortunately, that may not be the hospital's fault, but a lot of hospitals have now decided to do CHF follow-up, 2-day follow-up, 1-week follow-up, and then try and arrange this patient to see their PCP within a week or 10 days for follow-up of after an hospitalization. Again, it's 30 days should not be the goal of prevention of readmission. The goal should be prevention of readmission per se, whether it's 30 day, 60 day, 90 day. Our goal should be patients should not come back for the same condition unless their condition worsens from a disease standpoint. So, and again, this is the idea is just to guide you that the MedPAC has estimated that 12.5% of Medicare heart failure admissions were followed by a readmission within 15 days, and this accounted for 90,000 admissions at a cost of $590 million. So again, readmissions are expensive. This is why they're being looked at. All measures, for whether it's physician documentation or hospital process issues to prevent them, are being looked at. When you look at the analysis steps, there's a bunch of calculus equations in this. This is beyond us to understand how they calculate the cost. But what we need to know for the listeners of this group is readmissions are a big issue. They need to be prevented, but at the same time, the documentation should be rock solid at the time of discharge, saying, well, we discharged this patient in a stable condition, evidenced by A, B, C, D, E, F on the examination findings, on the EKG findings, on the lab findings. Now, CHF has also introduced this reducing readmissions. They have measures. Again, it's a quality net program. It's free for everyone from CMS. I just like it because they have put in so much community-based transitions care program that the hospitals can look at, not only for CHF, but for pneumonia, for MI. Now, we had made this flow chart on when a patient is readmitted. And essentially, when you look at the purple boxes, was that readmission clinically necessary, or was it not clinically necessary? When we go down the pathway of clinically necessary, question is, should this patient have been discharged on day 2, day 3, or could we have kept them another day? Or is there a failure of recovery, or is there new complications? And those are not, those are clinically necessary admissions. Someone with a CHF had an ICD, comes back with ICD firing or a 10-second ventricular tachycardia. There is no way to predict that will happen 2 days after discharge. But nosocomial infections, medication side effects, when we look at new condition unrelated to the index diagnosis, so you admit someone with heart failure, do the treatment, 4 days later they fall down and come back with a hip fracture. It is a readmission, but the documentation should reflect that it's not a readmission for a CHF exacerbation. This is a completely different diagnosis. And again, scheduled readmission. A lot of times you do cardiac catheterizations, whether they're planned or scheduled for stents in areas 2 weeks later or 3 weeks later, or you've already put in 2 stents and you think you want to try 20 days of medications and then look at the third artery, whether it needs a stenting or not. But again, it needs to be documented. Now look at the not clinically necessary readmissions. These are the inappropriate or the non-clinical readmissions, and this is the economic and psychosocial issues. Patient, you prescribed Lasix, and this patient should have been on Coumadin for AFib. Turned out they didn't have money, or the usual issue of medications got lost, but now they're back in for pain medications. In the inappropriate section, this is where the incorrect assessment is. Patient had heart failure, you couldn't do an echo you treated for simple pneumonia, sent them out, or treated for COPD. Turned out this was a diastolic heart failure with that didn't get the diuretics, the ACE inhibitors, the beta blockers, and then these are preventable complications. So when you have not clinically necessary readmissions, this is where not only does the hospital get dinged, but the provider also gets dinged. And with the increasing transparency of provider care and value-based care, it's not long before each provider will have a score in terms of how risky are they. If I have CHF, I can look at hospital A and check out the 10 providers and say, I want to go to provider 1 who has the least risk of morbidity, mortality, and readmission. So this is an equation that we had come out, 6 guys, 4 CMOs, myself, Ernie De Los Santos from Appeal Academy. We'd come up with this equation to predict the number of audit cases. And it's been validated with smaller hospitals as well as a bigger hospital, but its bed occupancy rate is a fraction of internal audits, fraction of audited cases per physician, EMDRG audits, readmission rate, length of stay, number of annual discharges, and it gives roughly a number. Now we validated it for COPD and then extrapolated it for heart failure. So for this 250 bed hospital, they had about roughly 169 discharges of heart failure with comorbid conditions. Average payment was about $5,800, and the savings were about $120,000 with proper documentation for just heart failure with CC. So the DRG of 292. Now, links have been provided at the end of the presentation, and these go to ACC and Medicare and guidelines.gov. But to summarize, it's just important to have the documentation right for all the reasons that we discussed.